Hi, everyone. I'm Ben Jacoby, and I'd like to welcome you to my presentation on advanced perio treatment made easy and profitable for the hygienist and GP and specialists, sponsored by my company, Ben Tips. Please note my email address here. If you have any questions, I'm always available. And a quick bio on me. I am a clinical periodontist. I have a practice in Kona, Hawaii. I got my dental degree from UCLA in 1987, did a perio residency at Baylor, and got out in 1991. I am the president and inventor of Ben Tips. Incidentally, I'm also the inventor and original patent holder for the periodontal endoscope and perioscopy, and also the inventor and patent holder for several anti-infective implant designs that are currently undergoing development in Switzerland. I do also provide other CE lectures. Feel free to shoot me an email if you'd like an invite. I do it monthly. They're 3-hour lectures. One is peri-implant infection diagnosis and treatment, and the other is the benefits of plant-based nutrition. I review the medical and dental literature, about 4,000 clinical studies. We cover a lot of material. So a quick overview here. Why are we here? Well, when I visit with my referring dentist colleagues, I see a lot of clinical problems and business problems. Specifically, periodontal and peri-implant disease, as you know, are extremely common. If we look at the CDC data, we can see upwards of 100% of the population is affected depending on the cohort that you look at. And current treatment modalities really have a lot of major shortcomings. Specifically, there's a lot of treated perio patients walking around with active periodontitis, but I do have a solution for you. So first up, some definitions here. Periodontal disease. We turn to the American Academy of Periodontology glossary, and we have the usual suspects, gingivitis and periodontitis. Gingivitis is inflammation of the gingiva only, and it is predictably reversible, and that's good. Periodontitis is characterized by the same inflammation, but also attachment loss, bone loss, and periodontal pocketing. Unfortunately, it's not predictably reversible. As far as peri-implant disease goes, we also turn to the AAP glossary, and we have peri-implant mucositis that correlates with gingivitis and peri-implantitis that correlates with periodontitis. Peri-implant mucositis is characterized by inflammation of the gingiva only, and it also is predictably reversible, whereas peri-implantitis includes the same inflammation, bone loss, pocketing, and in this case, you know that the pockets may actually predate the infection. Unfortunately, this is not predictably reversible and actually very difficult to treat. How to diagnose these diseases? Periodontal probe is the only way to do it. And we're talking about full mouth periodontal probing, charting pocket depth, bleeding on probing, and pus. That's every tooth and every implant. 6 sites per tooth or implant. Minimum frequency is annually in adults. That's right, every year. And for those patients that are at risk for these diseases, it needs to be done at every periodontal maintenance appointment or implant maintenance appointment. And the reason is this charting, this exam is going to drive your treatment decisions during that cleaning appointment. This is the standard of care. Quite a few references about that. I put one at the bottom here for you. Some of my colleagues will push back and say, Ben, in this day and age of shrinking reimbursement, I just can't afford to be able to do this sort of charting with a prophy. And my response is, I wouldn't recommend anyone working for free, is to charge out for D0120, periodic exam, do the exam, and you can do the charting under that and get reimbursed that way. Some of my colleagues say to me, well, we do spot probing. Spot probing is not okay. And this is an example why. So this patient was seeing the same dentist for 20 years. And then she decided that she wanted orthodontics. So she went to our friendly neighborhood orthodontist who said, oh, sure, we can straighten your teeth, but you got to go see Ben for periodontal clearance. So she came to see me. I did full mouth periodontal charting, and we found several areas like this. And so this is what we see with spot probing, because we tend to be creatures of habit. So we tend to miss the same spots over and over again. This patient wasn't very happy, as you can imagine. Probing of implants is definitely the standard of care. There's a lot of literature on this. I get some pushbacks from some of my colleagues say, oh, we don't want to disturb the long junctional epithelium. But the thing is the long junctional epithelium will reform rapidly, and in the presence of bacteria and infection, the long junctional epithelium will unzip very rapidly. And with the prevalence of this disease, it is really incumbent upon us to identify it, and the only way to do that is with probing. Always recommend using a plastic probe if you can, so we don't scratch any of those subgingival surfaces that would create another niche for infection, bacterial growth. Prevalence of these diseases? Well, we're looking at periodontal disease first in the USA. Please keep in mind that this is on a patient basis, not particular teeth, but we're going to divide up and categorize that for implants so you get a better picture of what's going on. So for gingivitis, Americans over the age of 18, basically everybody. Periodontitis in Americans over the age of 30, about half. And my favorite statistic, because this is the age group that I see a lot of, Americans over the age of 65, about 65% have moderate to severe periodontitis. How about the prevalence of peri-implant disease? It's very common. So peri-implant mucositis, about 63% of patients that have implants will exhibit this inflammation, and 31% of implants. So what this shows us is that in patients with multiple implants, not every implant is infected. As far as peri-implantitis goes, with the bone loss, almost 1 in 5 patients exhibit this. And look at this, double the prevalence in smokers, as if we didn't know that smoking was bad, right? And about 1 in 10 of implants exhibit this. And that might not seem like a huge amount, but if you're restoring a lot of implants or placing a lot of implants, this can be a real problem because it's an extremely difficult disease to treat. As far as the disease process goes, you're very familiar with this. It's microbial colonization of the tooth implant surface that leads to gingival inflammation. And so what are the clinical signs of gingival inflammation? Let's take a little detour here. So gingival inflammation is characterized by one or more of bleeding on probing, pus, redness, and swelling. You know this. Bleeding on probing is interesting in that one site that has bleeding on probing at one visit could be trauma from the probing. Whereas what we see statistically is if the same site repeatedly bleeds on probing, then we have a very high correlation with inflammation and risk for attachment loss. Pus is actually kind of the opposite in that every site that is infected will not necessarily exhibit pus, but if you see pus, that 100% means it's infected. So back to this, gingival inflammation increases the risk for alveolar bone loss and PDL destruction, which then increases the risk for tooth implant loss. And the gingival inflammation also increases the risk for systemic disease and premature death. Here's just one of many examples. There was found a 90% increased risk for cardiovascular disease with gingival inflammation. And this study showed a 52% increased risk for oropharyngeal cancer. Many other types of cancers are increased in risk as well. I'm sure you're familiar with that. This is one that surprised me. So this is scientific reports put out by the publisher of the journal Nature, which is arguably one of the most respected journals there is. And what they found is independent of cancer and independent of cardiovascular disease, that gingival inflammation increases the risk for all-cause mortality by 186%. Our patients walking around with gingival inflammation is just not okay. So as I tell our patients, by treating this disease, we save teeth and we save lives. So what are our treatment goals here? Well, we're looking for clinical periodontal health. And that means no signs of inflammation, no bleeding on probing, no pus, no redness, no swelling. That's our goal. It is actually attainable. So what kind of treatment are we talking about? Well, I'm going to venture a guess that for most of the participants this evening that we're talking about non-surgical perio treatment, if you are doing full flaps and osseous recontouring, props to you. Very cool. So non-surgical treatment, we're basically talking about scaling and root planing. And if you think about it, even surgical treatment, the basis is SRP. So anything we do, we're basically getting to the root surface and doing mechanical debridement. Of course, you're probably using some adjuncts as well, hopefully perioscopy, maybe systemic antibiotics, lasers, localized antibiotics, irrigators, rinses, perioprotect. What about the outcomes in the research as far as non-surgical treatment goes? In other words, does it work? It does, but please keep in mind that the periodontal research shows ideal conditions for the most part, and these are best case scenarios. And the reason is these studies are usually done at like a university perio grad program by the perio grad students and their periodontist professors. They oftentimes get extended amounts of time. I've even seen studies where they have an unlimited amount of time to render treatment, and they do extremely frequent recall, such as doing periodontal maintenance weekly, or even getting these patients in so the perio grad students are brushing and flossing for the patients. Not something we can really replicate in private practice. We wish, right? So as far as the outcomes go, what do we see? And these are ideal conditions. Stambaugh found pockets deeper than 3.7 millimeters could not be effectively instrumented consistently. Sherman found that after scaling and root planing, 50% of surfaces had residual calculus. Werhog, one of the most respected researchers and prolific researchers in perio research, found after scaling and root planing, 90% of teeth exhibit residual subgingival plaque. And subgingival plaque is always associated with inflammation. And if that wasn't enough, Renvert and Person found residual probing depths are predictive of further disease progression. So as dentists, hygienists, and working in tandem with our patients, we are on this constant quest for clinical periodontal health. But there's something getting in the way every time, and that's deep pockets. So if we look at like a representative graph of post-treatment periodontitis, basically perio recurrence or treatment failure versus pocket depth, as you know, the deeper the pocket depth, the more disease recurrence we get. But down here in the 1 to 3 millimeter range, in the shallow pockets, we basically get no recurrence as long as we have good oral hygiene. So this is what we're going to focus on. So I'm going to ask you to beware the fake 4. And the reason I pick out 4 is in this range, it's very tempting to say that we can always handle 4s non-surgically. But let me show you something. I see this fairly often, not just from us. So this is a case that was scaled and root planed by a very diligent and well-trained hygienist. I say that because I trained her myself. And then the patient went through 2 periodontal maintenance appointments, but the patient kept coming in with these 4 millimeter pockets in the mandibular anterior region with persistent inflammation. There was a lot of profuse bleeding on probing. These weren't 4s. So I went in here with bend tips, and that's what you're looking at immediately post-op. So I recontoured the gingiva at a lower level, and look at all the residual calculus. So because the gingiva was so thin, we couldn't probe past these rings of calculus. We thought they were 4s, but they were really 5s and 6s. And when we got all the calculus off, then everything healed up nicely. In this case, what you're looking at here after the procedure is 1 to 2 millimeters deep. So beware the fake 4. After scaling and root planing, if there's deep inflamed pockets, some of my colleagues will say, but we'll just maintain it. No. So this is not health. Patients walking around with deep inflamed pockets. It is active periodontitis. It requires definitive treatment. Otherwise, our patients are at risk for premature death and tooth loss. So in summary, we've got deep periodontal pockets that puts the patient at risk for residual plaque and calculus that leads to persistent inflammation, more attachment loss, and increased mortality. That makes the pockets even deeper and harder to clean. And this is just this vicious circle here. Where we need to intervene really is the deep pockets. Deep pockets are bad. And as I'm sure you're aware, even our patients know this. Even though we need to focus on the inflammation, the patients always focus on those numbers. Patients hear a 4. A lot of our patients are like, oh no, I got a 4. I even had a patient yesterday that when I started calling out 3s, she gave me a funny look and said, that's not good. And it took me 20 minutes to explain this. Clean 3s are okay. But wait, even deep pockets without inflammation are okay. The literature is very certain on this. They're called healthy deep pockets. And this is where we find them in fantasy land. I think in my 30 years of practice, I've seen just a handful of patients like this. It's extremely rare. It requires meticulous oral hygiene on the part of the patient. And then when they go off on a 3-month cruise and forget their oral hygiene implements, then the inflammation comes back. They're at high risk for inflammation. And because the areas are deep and they can't get to the bottom, then they require treatment again. So what else can we do? Well, we can do scaling and root planing and excisional new attachment procedure, or gingivectomy, modified Whitman flap, osteosurgery. These are all surgical modalities, and these all provide excellent calculus visualization. And that is the big shortcoming of scaling and root planing, is the lack of visualization. But do these all provide definitive pocket elimination to reduce the risk? Nope, but these two do. Gingivectomy and osteosurgery, these are both surgical modalities that provide pocket elimination, but they typically require advanced training. They're very time consuming, and it's not like we can delegate these to our amazing hygienists. There are additional advantages to pocket elimination, one of which I like to call strategic retreat, if you will. So here is an example. Let's say we have a very deep pocket with lots of calculus, and how clean do we have to get this root surface for success with scaling and root planing? Basically 100%, right? 110%, I'm being facetious here. That root surface has to be meticulously clean to mitigate the inflammation in the gingiva here. But as we know from the studies, that's basically impossible to do. So what if we do a strategic retreat, pocket elimination? Let's say we remove the gingiva. So instead of removing the bacteria to reduce or eliminate the inflammation in the gingiva, we move the gingiva away from the bacteria. So let's say we scale and root planed this, the area right near the remaining gingiva at our new gingival margin. But what happens if we leave this area? So this is all nice and clean. We leave this. Is there a problem here from a periodontal perspective? Nope. There won't be any recurrent inflammation as long as the patient keeps that clean area clean, and we do too. And the reason is the microorganisms from all this residual calculus are too far from the gingiva. They have about a 3 millimeter sphere of influence. Now, I'm not recommending you leave all this calculus, but one of the advantages here of the pocket elimination is the residual plaque and calculus is not pathogenic. Of course, now we can see everything, so we can get this root meticulously clean and get all this debris off. And most importantly, the patient can keep everything clean. And all of our clinical studies show this is the most important part. Shallow is good, and this is our goal, and that's what we do as periodontists, typically. Although this is advanced perio treatment. So advanced perio treatment, how do we get there? Well, we're taking signups for 3-year perio residencies, but I would imagine that you probably have other things you'd rather do, or maybe you completed one already. So BenTips is the answer. It is simple and easy. It provides pocket elimination, complete visualization, complete calculus removal, and our amazing hygienists can get involved depending on the state, because we're very much doing something similar to curettage. I think you're going to see improved reimbursement, as I'm going to show you in a moment. And there's going to be low equipment costs. This was a primary goal. I'm just shocked. I guess I'm dating myself when I see all this $100,000, $200,000 dental equipment, and I just can't wrap my head around that. So I wanted to keep the cost very low. It's very portable. You can take this operatory to operatory. And if you want to do Dentists Without Borders and go on a mission, we can airdrop you into the Congo, and all you need is a bucket of water and a generator, and then you can treat the world's most common chronic infection. So let's do a system components overview for the BenTip system. At the core of the system is the piezo surgery unit. Mounted on the handpiece are these shafts, and mounted to the shaft are these ablative tips. This is not a piezo scaler. It is a piezo surgery unit. This can be detuned to be used as a scaler, but it is classified by the FDA as a bone drill and a scaler. And it's used by periodontists, oral and maxillofacial surgeons, and even neurosurgeons and other medical specialties to cut bone. Very, very powerful. So now we're going to review some treatment techniques in some cases. So let's say we have a case like this, deep pocket with lots of calculus. We take our bend tips, we put it into the pocket and power it up. It ablates the gingiva, opens it up, and so now we can see everything. And it works very quickly. There is minimal bleeding. And the reason is this is actually acting as a harmonic scalpel. And what that does is it ends up sealing the blood vessels, so we get much less bleeding, even to the point that one of my colleagues asked me to come over and treat his father, who was in his mid-70s and taking Eliquis, an anticoagulant. And we were all wringing our hands because he was in pain. And we were talking about consulting with his medical doctor to get him off the Eliquis, but we had to treat him. And the area was like 9 millimeters deep with lots of pus coming out of there. So we used the bend tips, opened the area up. There was no bleeding. I could see the entire root surface down to 9 millimeters. It was amazing. So you get excellent visibility. And then this calculus comes off so quickly when you can see it. I like to call this enhanced scaling and root planing. And I see no reason why the hygienist can't do it, because it's very similar to curettage. So here's an example case. It's rather an extreme case. So as you can see, we had very deep probing depths, upwards of 8. And so I went in here with bend tips and I degranulated the infrabony defect, because that's what we're dealing with here. It's an infrabony defect. And at that point, there was minimal bleeding. I could see all the way down the root surface and get it meticulously clean. Interestingly enough, I'm putting this reference here for you. This is one of several from the Scandinavians. And I like to bring up the Scandinavians because they are the rock stars of perio research. At least I think of them as such. Venstrom, Lindy, and Neiman. There's a whole group of them. The list goes on. And what they showed in this particular study, in the context of a modified Woodman flap procedure, that if you degranulate infrabony defects like this and then maintain the area meticulously plaque-free, that you will consistently see tremendous amounts of bone regeneration in these defects. And that's without any fancy grafting techniques, guided tissue regeneration, Emdogain, nothing. They just regrow. And I think that shows the amazing regenerative capacity of the human body in the absence of insults like these very virulent bacteria. The other thing that comes up, I get questions, well, Ben, what about the attached gingiva? Aren't you cutting that away? And yes, we often do. So let's look at the result. So here the patient is a few months later, and you can see we have shallow probing depths and no significant signs of inflammation, and the attached gingiva has regenerated. And that is consistent with, again, the research from the Scandinavians that showed in cases like this, the attached gingiva usually regenerates. But even if it doesn't, they showed that there's really no increased susceptibility to infection or periodontal breakdown just because you have mucosa up against the tooth surface. Again, the Scandinavians. So, quick summary, what about the attached gingiva? Yes, we often remove part or all of it. Yes, it usually regenerates. And no, it's not a problem if it doesn't. Now, if we do this internal ablation, but we start leaning the tip out a little bit, you can see geometrically, we can start to do some pocket reduction. And if we take it to the extreme all the way out, then we're doing what I like to call external or horizontal ablation. And at this point, you're doing maximum visualization, maximum access, maximum pocket elimination. And at this point, I don't see any reason why you can't bill out for gingivectomy versus scaling and root planing. And I think you'll see the gingivectomy is significantly more adequate in the reimbursement, if you will. So you're offering more, doing more, getting reimbursed more, and all with increased efficiency and time savings. This goes really quickly. And that's good for our patients and good for us. As a patient explanation, there's two ways to approach this. I'm very diplomatic. So I like to say that this is like trimming our cuticles at the nail salon so that there's no places for bacteria to hide. And it is a life and tooth saving procedure. Some of my colleagues that are doing this procedure use other not so euphemistic phrases, if you will. And I'm going to save that for our podcast that we're going to put on with Viva. So I think you're going to get a kick out of that. We're going to interview my colleague across my parking lot, general dentist with 2 hygienists that are using the bend tip system almost on a daily basis. And he's a lot of fun to listen to how he explains this. So here's a patient example. Patient A, she's a 35-year-old female, recently immigrated from China, never had her teeth cleaned before. Medical history was non-contributory. She was referred from her new general dentist for perio evaluation. Her chief complaint was, I want to get this gum problem fixed as soon as possible. The interesting thing was she and I could not communicate because she only spoke Mandarin. But we both had WeChat on our phones. So we would text each other as we sat in front of each other, and WeChat translates from Chinese to English and English to Chinese. So it was really a hoot. We're sitting there talking to each other, and it was a lot of fun. Anyhow, this is what she looks like. Not happy, healthy gingiva by any stretch of the imagination. You can see we have pocketing upwards of 9 millimeters deep, all signs of inflammation everywhere. This is pre-op. This is immediately post-op. And even with all this inflammation, I would say this is probably the most bleeding that I see during a procedure is right here. I have to apologize that I didn't get a picture of all the big fat rings of calculus. I was on a roll and having way too much fun blasting all that calculus off, and I forgot. But this is what it looks like all cleaned up. And so here she is 1 day post-op. Now, I wouldn't normally call my patients in just to get a photo. I wouldn't do that. But she wanted the maxilla done 1 day, the day before. And so here she came in for the mandible the next day, ready to go. She told me that she took 1 Tylenol and was feeling great, no problems, ready for the mandible to be treated. Here she is 3 weeks post-op, all healed up, shallow pockets, I wouldn't even call them pockets anymore, and no significant signs of inflammation. And we see her to this day. We did ask the referring dentist to take out the wisdom teeth. It was just too hard for her to clean back there. So before and after in one simple bend tip step. So let's say we have a situation like this, where we've done the gingivoplasty or gingivectomy, and we've got this unfavorable bony contour, if you will, here, that as the gingiva may want to provide an extra cushion, it may regrow and make it hard for the patient to clean this area. So we need to address this. So we actually have special inserts that will allow you to go in and recontour this bone. And you can do it like this in a minimally invasive manner. Sometimes a suture is needed, sometimes not. And then it heals up. And at that point, you're doing osteosurgery. So 4260 for 4 or more teeth, or 4261 for 1 to 3. And I think you'll see that the reimbursement on this is much more adequate, as I'm about to show you. So I'm going to show you some fees here. And of course, we've got to be really careful about this. I'm not making any fee recommendations. Don't want to make the federal government upset. No fee fixing or anything like that. And actually, the fees I'm going to show you are nothing like my fees at all, and I'm not recommending them. And they're freely available on the internet. Here's the URL. I just randomly pulled them down. And so I guess this is the Texas Health Plan listing, and it covers general dentists and specialists as well. So it's not like I'm picking out any special group here. So let's say you do a single tooth scaling and root planing on this plan. From what I can see, you'd be reimbursed $93, or you could file a claim for $93. Single tooth scaling and root planing. Now, let's say you did a bend tips procedure on a single tooth, and because you're doing gingivectomy or gingivoplasty, it looks as if you can file a claim for $246. I would call that much more adequate reimbursement. Now we're paying the rent. At this point, when we're recontouring the bone and doing osteosurgery, which doesn't really take much more time to recontour a small area of an unfavorable bony contour, look at this. I would call this much more favorable reimbursement. So now we can pay our staff and pay our rent and feed our families at this point. And so I would ask you to compare and contrast your fees here. So as far as reimbursement goes, check your fee schedules, look across these. Your reimbursement may vary. So bend tips for implant disinfection and pocket reduction. So this is an example of implant disinfection. Patient B, 60-year-old female, referred for implant infection without complaint, non-contributory medical history. I could not attain accurate probing depths because of the crown design and the irregular subgingival contours. Although I did find several 5mm plus pockets with a bunch of pus coming out. So this is what it looks like, not happy, healthy gingiva. You can see we've got some contours that make it very difficult for the patient to clean, not necessarily outside the standard of care, because we're dealing with narrow platform implants, small diameter, that we need to expand up into a normal occlusal table. And so we end up with these contours. So I'm not faulting anyone for making them look like this. This is what the lingual aspect looks like. The blood you see is because I just did probing. So this is what it looks like after a bend tips procedure. I opened everything up, and you can see we've got this big infrabony defect on the distal of the left implant, and the surfaces of the fixtures are exposed so we can get them nice and clean. And this is what the patient looks like a few months later. And this is the lingual aspect. So you can see everything is much more cleanable and accessible for the patient and us. So before and after, again, in one simple bend tip step, and you can certainly do this in your office. And this is what the lingual aspects look like. You can see now it's much easier for the patient to get in there and clean, especially on the right implant. So bend tips is a brand new treatment modality. It is predictably effective. It provides full access, which means no residual calculus, no pockets, and this makes it accessible for our patient and us. It's quick and easy. Let us show you. I like to describe it like riding a bike, but kind of in a different way. So once you know how to ride a bike, it's easy, but there is a learning curve. We just need to teach you how to do it. And our amazing hygienists can get involved depending on the state. And this really makes financial sense. It's affordable for us and our patients. And what I've tried to do is make a price target to keep it affordable. You'll see with the promotion that's offered. So the entire system will cost about $10K. It will provide adequate income, in my experience. And reason is doing gingivectomy or osteosurgery if you haven't done those before. We're going to do a review of system components of the bend tip system. So these are the shafts that attach to the handpiece. Currently, we provide the shaft 90 and shaft 45. And as dental professionals, I'm sure you can appreciate these different angulations allow us good access to different areas of the mouth, and that's what they're for. Then we have the tips. All of our tips currently are made out of PEEK, which is polyether ether ketone. You may be familiar with it, but if you're not, it is an amazing, very hard, very biocompatible, autoclavable plastic. They even make spinal implants out of it. That's how biocompatible it is. This particular tip is my favorite, and I like to call it the original tri-tip. It has nice sharp edges, and it's very, very narrow. So it's great for getting into interproximal areas, such as in the mandibular anterior region. And it has these sharp edges, so you can actually cut with it. The drawback of this is you got to have a light touch. Otherwise, you might snap the tip. If you do, it's not a huge big deal. The tips tend to stay where they are, and they're just a couple of bucks a piece. This is the stubby tri-tip. It's much more robust than the original tri. Disadvantage here is that you can't reach as far interproximally, but because it's so robust, it's great for like palatal gingiva recontouring or something like that. You can really lean on this one without any fear of distortion or anything. This is the modified tri-tip. It's kind of in between the stubby and the original. It will go interproximally, and so you can access gingiva there, although it's not quite as robust as the stubby, but more robust than the original tri-tip. This is the bulldozer of the group. This is a very strong tip, and it may not reach very far interproximally, but it's great for recontouring, say, large area of palatal gingiva on maybe a smoker with a thick gingival biotype. Great for planing that down. You can actually use this for internal ablation as well, like on the distal of mandibular molars, where you might have a third molar defect. So it has many uses. This is probably, I would say, the second most favorite of the tips that we offer. This is probably the most favorite. I call it the hygienist's best friend. This is the star tip. And so it has these 5 edges, and it's very good for ablation. It's really good for doing the internal ablation, going down in the pockets and degranulating those areas. Now we're going to review some system capabilities. So as I showed you, we can do internal ablation and external ablation, but we can also do aesthetic gingivoplasty. So this is patient C. She's a very sweet 32-year-old female law enforcement officer. I think she was a sheriff at the local facilities, and she was referred for aesthetic gingivoplasty. Her chief complaint was, I don't like my gummy smile and short teeth. Medical history is non-contributory. Perio exam was basically non-contributory, except for my assessment of, and her assessment, on aesthetic gingival display and on aesthetic maxillary anterior crown aspect ratio. So this is what she looks like with a slight smile. You can see she does show too much gum tissue and her teeth are kind of square. This is what she looks like with lips retracted. And you can see we also have kind of a bulbous frenum. This is what she looks like immediately post-op. I use the bend tips to recontour the frenum and also to reshape the gingiva, so the gingivoplasty. But when I was done, what I found is my probing depths from the osseous crest to the new gingival margin was like less than 1 millimeter. And that's not okay because the bone is not going to tolerate that. It would most likely regrow the gingiva. So I flapped the case and then went in with the gold-tipped bone recontouring inserts, reshaped the bone, and then replaced the flap and sutured it. The nice thing in this case about the gingivoplasty is you have just perfect control in reshaping the gingiva with these tips. So here she is before and after with lips retracted, and before and after with a smile. She still shows some gingiva, but she was very happy with this result. Next up is cleaning of implants and abutments in place. So remember this case, we got to keep these areas clean. And there's nothing better than like the star tip to get in these nooks and crannies and even subgingivally to get soft deposits off. It's not like you're going to be blasting off large amounts of residual cement or calculus. Some will come off, but for the most part, this is about soft deposits and most importantly, not damaging these surfaces near or underneath the gum line so that we don't create additional areas for the bacteria to recolonize. Next up is scaling with the gold scaler inserts. So when I'm using the bend tips to recontour the gingiva and expose all this calculus, I could be putting on inserts onto the bend tip system to use it as a scaler, but that takes extra time. So I love having a scaler handy. My favorite happens to be the Parkel turbo sensor. I'm sure some of you have that. I've used the Bone Art. Of course, there's Cavitron and Beaver and Woodpecker. They're all good. And then, so these are sitting next to you. You pick that up, blast off the calculus, and then keep going with the bend tip system. You can go back and forth easily, and you don't need to take all the extra time it would take to swap out the inserts on the bend tips unit for scaling. But remember this case, calculus like this can sometimes require like a high-speed handpiece to grind off. I've had cases like this, and if you work in like a rural clinic, you know what I'm talking about, where you just wish you could increase the power on your ultrasonic to get this clean because it's just taking forever. Well, we do have gold inserts for this, and with piezo surgery power, it's like a jackhammer, and you can make very, very short work of this calculus and get it right off. Next up is root planing. We've got gold diamond-coated inserts. Here's a small selection of them, fine and coarse. You know, every girl's best friend, right? Diamonds. And so these are very good for root planing, and you can even dress down the root surface, remove enamel pearls or enamel projections. Theoretically, you could even do a prep with these things. They can be very aggressive, so you do have to be careful with them. But what I do is I turn it down to scalar power and then go in and root plane with them, and we end up with fantastic results and smooth root surfaces. Next up is osteoplasty. You can use this for crown lengthening and implant site preparation. And so this is one of the bone reshaping tips. It has smooth sides, so you can get this right up against the tooth structure and it won't damage it. If you look at the end, you'll see that it has a very aggressive tip for cutting the bone. And so if you're going in a minimally invasive manner underneath a flap to recontour the bone, we actually have the irrigation coming right out the end. And that way that you won't necessarily overheat the bone due to a distant irrigation port. Theoretically, you can also do implant site preparation with these. So here's a case to show you the osteoplasty. The gingiva didn't look normal here. There was just something wrong, even though I was only probing like 4 millimeters. So this just looked very odd to me. So I flapped the site, and as you can see, we have a crown margin that is less than ideal. And you can also see that we have an osseous crest that is in very close proximity to the tooth margin. So we're going to have biological width problems here. On the right, you can see that I've already recontoured the bone, and we're about 3 millimeters from the osseous crest to the tooth margin. And I think you can also appreciate this tooth margin, the way it's sticking out, and the reason why when I was probing, I was hitting tooth structure. I wasn't getting to the bottom of the pocket. That's what we got right here. That's the tooth margin, not even close to the crown margin. So here it is, sutured up, and now the area is completely accessible for our restorative dentist to fix it. Next up is sinus grafting, using the sinus lift insert kits. If you've done sinus lifts, you're very familiar with these. There's nothing unusual. We've got the elephant foot and the ball, diamond, the usual suspects, if you will, for doing sinus lifts. Last but not least, we've got a whole set of bone cutting and other inserts. You could do ridge splits with these, osteotomies, block graft harvesting if you needed to, cortical plate graft harvesting, and even some periotomes for doing extractions. So now we're going to go over some use cases. This one is obvious. So new patient comes to your practice, they have deep pockets and signs of inflammation. You schedule them for bend tips, do gingivectomy or osseous surgery instead of scaling and root planing. And depending on the state, our amazing hygienists can anesthetize the case, do the internal ablation and the scaling and root planing, and then the dentist comes in and does a little bit of external ablation. It just takes a few minutes, and then you've done definitive pocket elimination and get reimbursed accordingly. Use case number 2. This may not be so obvious. So let's say you have a prophy patient that comes in and they only have one deep area. So perio recurrence in one spot. They might look like this. So they're stellar in all areas, but they got this one pesky lesion down here. Well, how about same-day bend tips procedure? It only takes a few minutes. So the hygienist anesthetizes, does the internal ablation and the SRP, and the dentist comes in and does the external ablation and any little bone recontouring that might need to be done, and then bill out for single-site gingivectomy or osseous surgery. And we say the patient gets a free prophy. That makes them happy. Of course, many of us are working in an environment of being participating providers. And I don't know what happens in your area, but in our area, if we do a procedure like a gingivectomy, they'll disallow the prophy. So we just tell the patient they get a free prophy. But the reimbursement is much more favorable because every plan that I've ever seen, the gingivectomy and single-site osseous surgery was much more adequate than the prophy. Everything I've seen, the prophy is just a loss leader. So this is the bend tips use case number 3. And this is going to be very obvious for those of you that may work in rural clinics where patients have difficulty with access to care, such as those that never get any dental care. This was brought to our attention. We did our product debut at the ADA and had a booth, and we had a very nice hygienist come visit us that was very interested because she worked in a rural clinic. I think it was in Tennessee. And she said, yeah, I've got 30 dentists and hygienists working for me, but our hygienist can only see 4 prophy patients a day because they're dealing with massive amounts of calculus. So heavy calculus, severe inflammation. The treatment, How about enhanced scaling and root planing? Get access to this, do internal ablation, and then use the BenTips piezo surgery scalers to get all this calculus off on max power, used carefully. All that heavy, tenacious calculus, just like the movie, gone in 60 seconds or less. So for BenTips results, our patients, we're providing definitive treatment, minimal retreatments, and we have happy, healthy patients. I've actually had patients catch me in the hallway on their periodontal maintenance visits and say, Doc, I came in here with 9s and now I'm all 2s, and I just want to thank you for that. This is just amazing. I've actually had patients grab me and thank me. It's a very good feeling. As far as dental offices go, increased office income, increased efficiency, time saving, more patients seen. It's a happy, healthy dental practice with happy, healthy patients. So we do various types of training. We can do it remotely, or you're welcome to visit us. This is the amazing Outrigger Kona Resort. I don't get any freebies from these people, but love to go down here and have a cocktail out on the point where you can see manta rays at night. Great place to stay. Beautiful water. So we'd love to have you come out and visit and train you personally. You can stay here 5 minutes from the office. So if you have any questions or need any help, we're always available on our website. Just go to bentipsusa.com and hit the contact us button, and we're happy to help you answer any questions. So thank you very much for attending, and we'll do a quick Q&A here. So give me just a second. And I'd like to say hello to my good friend, Dr. Paul Yaroshevsky, my best friend from dental school. Good to see you, Paul. Thanks for attending. Excellent dentist. So Melissa says, why not do D0180 perio exam instead of 120 recall or 14? It's a very good question, Melissa. I've looked over these codes and tried to dissect them myself. That could be appropriate. So yeah, why not? I agree with you. And if you have any information, if you think this is more appropriate, then I would totally adopt that. So very good point. Thanks for bringing that up. Oh, thanks, Paul. Paul said I have a very light touch. So thank you for that. All right. Annalee asked the wrong question. She says, do you see nutrition playing a role in gingival health? And the reason I say you asked the wrong question is because you ask a simple question, you're going to get a 3-hour answer. So Annalee, I'd love for you to attend my plant-based lecture, but there is reams and reams of literature that does support what you're saying. And in dental school, we actually said that nutrition didn't play a role, but since then, we've got many studies that do. A plant-based nutrition, just simple off the top, we see that people that basically eat unprocessed fruits and vegetables are, they just have less gingival inflammation and better response to perio treatment. So again, I'd love to have you attend, and I can go into the details on that. Let's see. Talia says, wouldn't the gingivectomy contribute to root sensitivity? That is a very, very good point. And it really applies to all of perio, if you think about it, because as periodontists, we do pocket reduction, and that's what we're doing here. Interestingly enough, we don't see a lot of it. When we do pocket reduction like this and expose the root surface, I tend to use like a Cavitron to get the calculus off, but I'm not going in like doing meticulous root planing far away from the gingiva, because that could contribute to root sensitivity. Overall, the complaints we have, I would say over the past 30 years of practice, is what we see is patients with poor oral hygiene or parafunctional habits are the ones that have increased root sensitivity, especially in smokers. But patients that don't have parafunctional habits and have good oral hygiene, whatever sensitivity they have tends to go away very rapidly. We just really don't have much complaints with this. But thank you for bringing that up. Very good question, Talia. So Caitlin says, where can we find the list of states that allow hygienists to utilize this? Also, are hygienists allowed to do gingivectomy or osseous surgery? So my understanding, your research may vary on this, but gingivectomy and osseous surgery cannot be done by hygienists as far as I know anywhere. Not 100% certain, but I would say 99.9. As far as the states go, that's a really good question. I have looked through the states. Some states are very clear that curettage is allowed. Some are clear that it's not allowed. And then there are a few that you really can't tell. So my recommendation would be to call your state board, or I would imagine there's probably some very savvy hygienists in our audience that know this answer. Unfortunately, I couldn't figure it out because the statutes are not real easy to read. Okay. So Jason says, how do patients tolerate the large food traps remaining after treatment? Excellent question, Jason. Thank you for bringing that up. And it's a thing that we deal with as periodontists doing pocket reduction surgery, so it applies to both. So what I do is I tell our patients, I say, we are going to reduce the height of your gum level. And I even have a diagram that shows the food traps. We call them black triangles. And it's going to happen, but it allows our patients to clean it. Most patients, I would say 99%, as long as we let them know up front that this is going to happen, they don't have a problem with it. And they appreciate the ability to clean these areas. And let's see. And so Latosha says, how can I find out if my state allows hygienists to use the bend tips? As we said previously, it's an excellent question. I would recommend calling the state board or talking to maybe the hygiene society in your area. They might know. Let's see. Okay, so Sarah says, if you have 9mm probing depths with pus, do you ever prescribe antibiotics or do you only treat with local measures? Excellent question, Sarah. Thank you for bringing that up. So the literature we have is there's quite a few that show that metronidazole alone or amoxicillin and metronidazole, like a 7-day course, 3 times a day, 500 milligrams of each, that sort of thing. There's different regimens for it, but they're pretty close. We actually do see less recurrent disease and less inflammation after treatment. So I will typically prescribe this after treatment. So it does seem to work. And we do it most of the time, especially when I see a lot of inflammation. So in other words, if I treated a case that was all 5s with only bleeding on probing, I will typically prescribe amoxicillin and metronidazole in that case post-op for 7 days. Okay. So Tamara says, once the pockets have reduced to normal levels, would they go back to prophy or stay perio maintenance? Also a really good question. I think it depends on the pocket depth because it's really the amount of work you have to do. If the patient's twos everywhere with meticulous oral hygiene and you can get them clean in 20 minutes, I would advocate for a prophy. If you've got difficult areas, such as, let's say, the distal of a 3rd molar where there was or the distal of a 2nd molar where there was a 3rd molar defect, where after healing, maybe it was a 9 that went to a 4 or a 5, where you've got to get in and clean these areas. Or let's say the patient has 3mm pockets, but there's calculus that's recurring because their oral hygiene is not good, then I would say that perio maintenance would be more appropriate. If you're a participating provider, I think you have to look at the guidelines. Out here in Hawaii, some of our insurance companies say that you've got to have at least like 1 4mm pocket with inflammation. Then you're cleaning below the gum line and you can bill out for perio maintenance. Let's see. So Lindsay says, when doing non-surgical SRP, do you recommend placing LAA at the time of SRP or at the following appointment? So I'm assuming we're talking about Arrestin here. And so if we do use a fair amount of Arrestin. The only time we typically use it is after bend tips treatment if there's like a residual defect. Again, the classic example is a large 3rd molar extraction defect that became infected on the distal of a mandibular 2nd molar. So we go to reduce it, but because of the ramus, the 9mm pocket is clean, but it comes back as, let's say, a 5, and the patient's not cleaning back there. So we start getting recurrent bleeding on probing. That's when we start placing localized antibiotics like Arrestin. And sometimes we use a lot. And we also tend to use the local antibiotics around implants too, if there's recurrent pocketing. Like the case I showed you with the infrabony defect, it wouldn't be unusual to have a pocket heal up, but that might be 5 or something like that. So we would treat that if we see recurrent inflammation. Let's see. Thank you, Angela. And let's see what's next. So can bend tips treat severe perio case with mobility? Very, very good question. It depends on the mobility. I have seen, especially in the maxillary anterior region, we can have, let's say, Miller class 2 mobility with very deep pockets, maybe on only one side of the tooth. And so we'll go in there and get all that cleaned out, and we'll see what really looks like regeneration. I will get like a 9 going to a 2 without really reducing the height of the gingiva. And we see those teeth firm up. So it's really going to be on a case-by-case basis. When we get into the maxillary posterior, if you've got a maxillary molar that has like a Miller class 3 mobility with furcations all opened up and the patient can't get in there and clean, I tend to call those hopeless prognosis and recommend extraction. So a lot of this is driven by the patient's ability to clean it afterwards, because that really is what's going to drive your success. As I tell our patients, we make an area, it's like a reset button. We get the bacteria out, we make it cleanable, but then the patient's got to keep it clean. And this gets into a whole other area. We do a lot of oral hygiene instruction with our assistants. It's like a half-hour, 45-minute appointment, and we don't stop until those patients can really get themselves immaculate. And then we see 9s going to 2s all the time. Okay. Thank you, Dr. Rashid. You're always welcome. Let's see what's next. So Marina says, then at first is the root planing, and after that, the ablation with the scalar tips. So if a patient really has tremendous amounts of debris, we'll go in and do scaling and root planing first without the ablation. But if there isn't profuse amounts of or severe gingival inflammation, we'll go in with the ablation first to open everything up so you can see the calculus off. Because if to remove all the calculus, as you can imagine, if you've got all this gingiva covering the root surface, you can't see, right? So this is one of the disadvantages to scaling and root planing. You might be heavily scaling a root surface that has no calculus on it, and at that point, you're just damaging it. So we like to get visualization because you get very fast debris removal, and you're not causing any damage to root surfaces that don't have debris. Let's see. So Kendi says, I have a patient that comes in, not buildup, not bleeding on probing, not bleeding during cleaning, but 4 and 5 millimeters all the time. What would you recommend? Really good question. So I'd have to see, but if the patient is relatively young and healthy and their attachment levels seem stable, then an absence of inflammation, then they don't have periodontitis, and you would leave them. The thing that worries me that I think I see more often than not is these patients, they will be like high stress and smokers, and they are breaking down over time, and you could be dealing with an aggressive or refractory periodontitis case. I think the American Academy of Periodontology has renamed these, but these can be very, very difficult to treat. I've had trouble with them. We've actually had good results in some of these weird cases in patients that quit smoking. And the reason I bring that up is we have literature shows that tobacco products like smoking or even marijuana can destroy bone all on its own. So I tell our patients that are smokers, if you don't quit smoking, I can't treat the bone loss from the smoke. I can only treat it from the bacteria. And then I need your help with good oral hygiene. But what we do see in those patients that are non-smokers is there is actually a dilute bleach regimen that Dr. Jorgen Slotz has researched and published on. And we've actually seen this turn the corner on patients where it seems to stabilize them. Let's see. So Caitlin says, do you prefer ultrasonic piezos to hand scaling for SRP? Me, I, for the most part, go right to ultrasonics. If the root surface feels like it's kind of cobbled, then I'll use the diamond inserts to plane it down. And then also I will pick up a Younger Good 7/8 scaler to root plane it by hand. But overall, the research is pretty clear. There's no difference between the two, and there's quite a bit of research in this area. So it's really whatever you prefer, and then your patients too. Of course, you probably have patients coming in saying, no, they only want hand scaling. They don't like the ultrasonic. Let's see. Oh, sorry, Marina, I didn't understand that question. I hope I answered yours. Can we use strontium chloride for sensitivity cases? Excellent question, Amar. There's no reason you couldn't use it. And if anything, there's probably research to show some bactericidal activity as well for a Perio benefit. I like anything like this for root sensitivity if it works. over the years, we've had a very tiny handful, I would say maybe 5 patients out of many hundreds that really had persistent sensitivity that needed to be addressed. But yeah, I think it's a good idea. You could certainly give this a try. So the first thing that we try is Sensodyne. We tell the patients, really, really good oral hygiene, get everything meticulously clean, and then put some Sensodyne on it and leave it there for a few minutes. And the patients, it seems to take care of it. But yeah, strontium chloride, why not? Definitely. Let's see. Dr. Hassanian says, PDD is a very challenging part of dentistry, no argument. When do I need to refer to periodontist in terms of limit of the pocket numbers and AL? I don't understand the AL part, but I think I can address this. So I think it depends on what you feel comfortable with. I know general dentists that place all their own implants and do all their own pocket reduction with osseous surgery. So if you don't feel comfortable with that, then you could certainly go to Ben Tips and do it. Of course, I got to give myself a plug, right? But so what I see from my colleagues that are using the Ben Tips system as to when to refer to us, well, we noticed like a 98% drop in referrals. They tend to get more and more comfortable with the procedure. And I'm getting phone calls saying, yeah, Ben, we had an 8mm pocket the other day. We went after it and now it's a 2 and it's looking great. Basically telling me they don't need me anymore, which is good, you know. But it really depends what you're comfortable with. Most people that start this, what I recommend is only going after like 5 and 6mm pockets. Keep it simple. And it's very easy because once you get into the deeper pockets with a Ben Tip system, like at 8 or 9, then you're getting into connective tissue. It's more time consuming and it takes some additional techniques. But to start out with, I would say in the beginning, yeah, go all the low hanging fruit is the 5 to 6mm pockets and refer everything else. And you're probably going to be overloaded because all the practices that I see have tremendous amounts of patients with like 5mm pockets. Great question. So Marina says, it is root planing plus Ben Tips or just Ben Tips. So if it's just like what we're going to call it, it's whatever you'd like to call it. But like the Ben Tips procedure, you'd go in and do the gingival ablation and then scale. And then if you want to do root planing afterwards, you could use the gold tip inserts or your Gracies or whatever you like to use for the root planing. Let's see. So Dr. Gross says suggestions for interproximal plaque removal between maintenance visits, Proxibrush, soft picks, water pick, etc. Oh, he said the W word, the water pick. Just kidding. So the research on water picks, I don't want to bash Teledyne. They almost licensed my periodontal endoscope. They were a fantastic group of people. Unfortunately, that fell through. But all the research I've seen on the water pick just using water shows that there is no reduction in the hard clinical endpoint that is expected in periodontal research, and that's gingival inflammation. If anyone has ever seen a study where there's clinically significant reductions of gingival inflammation with the water pick alone, I'd love to see it. They kind of dance around the topic on that one. However, if you do put a dilute bleach solution in this, Lobene showed this, I think, in like 1979 or 78 or something like that, that if you use the pickpocket tip with the dilute bleach solution, you can see reductions in gingival inflammation. So that can be good, especially in furcations, although that doesn't address your interproximal question. So otherwise, Dr. Gross, you nailed it. Proxibrushes and soft picks are my favorite. I personally use soft picks all the time. So definitely, and the research is very clear that Proxibrushes are actually better than floss at plaque removal. So yeah, great. Thanks for bringing that up. And do I prescribe Paradex? Yes, we do prescribe Paradex. I use it as a crutch, if you will. So someone has had pocket reduction and it is a surgical procedure. They're going to be a little sore afterwards. So they can't brush and floss for a few days. And then we prescribe Paradex, but only until they can brush and floss again. I used to prescribe Paradex for anyone that came in with inadequate plaque control, but I was called out by a very astute general dentist that wrote me a letter on a mutual patient that said, Ben, why are you using permaparadex, which is what we call this, permaparadex? Because this patient's coming in every 3 months and we're beating up the restorations and we're beating up his teeth, getting the stain off. And I thought, dang, he's right. So what we do is lots of oral hygiene instruction and only do permaparadex on like our very elderly patients that have lost dexterity and really have no other way of controlling their plaque. But great question. All right, so let's see. If the hygienist does the curettage, how can you charge gingivectomy code? Excellent question, Jessica. I would say you can't because the hygienist can't do gingivectomy. So this is the reason why we say that the hygienist anesthetizes, opens up the case with the internal ablation, does the scaling and root planing, and then the dentist comes in a few minutes and does the final recontouring for the gingivectomy. And let's see. So that concludes the presentation. Thank you so much for attending. And please feel free to contact us. I'm always happy to discuss the system and any other questions you have. So again, I appreciate all the help. Hope you enjoyed it. Take care, everyone. Good night.